Hello, welcome to a discussion on modern dystocia, ancient perspectives on a timeless issue. This is the name of the honors thesis which I am currently writing and which I presented on at the Undergraduate Research Symposium at the University of Washington last Friday on the 16th of May. I'm going to be using the next 10 to 15 minutes to present why my research is important and why it's significant in the discussion of modern dystocia, or difficult childbirth. That's what dystocia means. Dystocia, it's a Greek word. So let's go ahead and begin. Every year there are about 4 million births reported to the CDC. In the year 1996, about 20% of these births, or roughly 1/5 of these births, were born via cesarean section. This number increased 63% from 1996 to 2012, where currently the rate of cesarean section is roughly 1/3 of all live births. Switching gears a little bit, over 99% of births in the year 2006 occurred at a hospital. In the same year, only a little over 1/2% were born at home. Since 2006 into the year 2012, this number of home births has actually increased almost 50% to roughly 1% of all births, and hospital births have decreased subsequently. In 2013, the American Congress of Obstetricians and Gynecologists released a statement suggesting that elective cesareans and other elective inductions not occur before 39 weeks gestation. This is an effort to try to reduce the cesarean rate by targeting 37 and 38-week elective cesareans and removing those from the pool of options for parturients and doctors. Healthy People 2020, which is a government initiative to set goals for each decade, set the goal for the year 2020 to be completed over this decade to be a 10% reduction in cesareans across the board. And the Journal of Midwifery and Women's Health did a study of 17,000 planned home births and suggests from the study that a planned home birth is both a viable and a healthy option for healthy women who are looking for low rate of intervention. Now, it should be said that a cesarean section could be seen as the epitome of Western medical intervention, since cesarean section in most cases, in almost all cases, can remedy any form of dystocia and does not make us choose between mother and child. That said, the home birth option could be seen as the avoidance of Western medical intervention. At least many women have choose a home birth for that reason. Now, why should ancient sources be included in the modern discussion of maternal and fetal health? Why do the ancient sources even matter? Now, I admit that accuracy is not always first and foremost an attribute of ancient medicine. Here we have an image of a uterus with a fetus, quote, in the natural position. It doesn't take much skill or experience to know that this fetus is disproportionate. In fact, it looks like an adult, and it's sitting, or should I say standing, upside down in the womb. The ancients did not understand necessarily what was going on within the womb here, but they did know what was, they were able to do quite a bit with what was presenting over here in the cervix and the vagina. And this is mostly because they didn't have things like ultrasounds to be able to tell what was going on inside of the womb. Another example is a retained placenta, and here we have a placenta. This is the maternal side of a placenta, and a placenta attaches on to the uterus in order to, and the placenta is fetal tissue, it allows for diffusion of nutrients and gases between mother or maternal and fetal blood. Now, normally what happens is the fetus is born, and then the placenta or the uterus begins to contract and actually forces that placenta to slough off. Sometimes, though, the uterus can contract and the placenta can hold on or be retained, but can still create a rift between the two layers. And that rift can actually start hemorrhaging or bleeding. I did have the experience when I was shadowing an obstetrician to be present when he was called by a family practice doctor who was experiencing an issue with retained placenta. This particular family practice doctor was pulling on the placenta, and normally it gives easily. Pulled a little too much, the cord ruptured, and he could not find, or she could not find the cord in the uterus in order to find the placenta. And so the obstetrician was called in because her patient was hemorrhaging. So the obstetrician reached in and was able to feather his fingers around the placenta and gently pull it out. And the obstetrician told me that this is something that is common, a common occurrence that he gets called in for about once a month or so when he needs to assist either a midwife or a family practice doctor, usually, in removing a retained placenta. And he said that usually the folks who are having issues removing a retained placenta, it's due to inexperience, whereas as an obstetrician, the doctor I shadowed was very comfortable inside of the womb and was familiar with it. Now, I should also mention that a woman who is hemorrhaging from this rift could lose quite a bit of blood. In fact, 20% of the blood at full term from the heart goes directly to the uterus. And so if blood is pumped once per minute completely through the body, 20% of the blood hemorrhaging gives a woman about 5 minutes, give or take a few, before she's lost all of her blood. Now, she will pass out long before she loses all of her blood. Now, having this experience, I then read a few months later in Serenus, who's a 2nd century medical author, Greek, practicing in Rome, who wrote an extensive book on gynecology, and he says that in order to remove a retained placenta, we have to work around it from side to side, and that issues regarding retained placenta and how to remove them result out of inexperience, either rupturing the cord so you can't find it, or pulling the uterus to inversion. So we have here an actual parallel where the modern and ancient sources actually parallel each other, and the information is actually held in a very similar way, where very experienced people hold it, a sort of elite, you could say, whereas those other people, even though this information is 2,000 years old, who don't see it as often, aren't able to perform what's known as manual extraction. So very similar circumstances. And here is our third example, which we will discuss, that is maternal mortality. I want you to pay attention to mostly the fact that this chart shows the last century of data regarding maternal mortality or maternal deaths per 100,000 live births. And I want you to notice that over the last 100 years, this rate has remained below 1,000 per 100,000, or less than 1%. If we were to go back much, much further than even the sources we've used, prehistoric rates can be estimated as 10 to 20 times higher than the highest rate here. That is approximately 10,000 to 20,000 deaths per 100,000 live births. And this has been argued using anthropological evidence at grave sites, digging grave sites and determining gender and cause of death. And so So here we have an example where for most of the century and most of our lives in modern society, we are unfamiliar with maternal mortality. In fact, we're very unfamiliar with maternal mortality, whereas our ancient sources are another thing altogether. In fact, here we have an example from Aetius, who's a 6th century author, writing on similar things as Serenus and others. And he says, before doing these things, that is, operating or intervening, he says it is necessary that the physician examine the parturient, the one in labor, to see whether she is feverish or not, and whether he can operate or should give up. Now, I find it very interesting when I read this that this dichotomy of operating or giving up, that there is even an option to give up. In fact, in modern medicine, with the exception of, say, cancer or heart surgery, neurosurgery, giving up is not an option. Those other areas we might give up because the operation may actually pose a greater risk than the threat we're trying to remove to the patient. But in obstetrics, this is not really an option, because in the ultimate case of ultimate dystocia, cesarean is an option and allows us to save both the mother and the fetus pretty successfully with very few complications or risks to either. And so giving up is not really in the vocabulary of a modern day obstetrician. So what? So why does any of this matter? Well, the reason why it matters is because we're not familiar with dystocia at the level of maternal mortality. And anytime we have questions regarding obstetrics, that could be personal questions like, who should deliver my baby? Where should I deliver my baby? Should I do it at a hospital or at home, at a birthing center? Or larger questions of a political or societal nature. What should the rate of cesarean section be? Should there even be a rate? Should we reduce the rate? Should all women just have to have a cesarean? And some of these are extreme questions, but they get at the heart of what is going on right now in the discussion that's going on regarding the cesarean rate and home birthing, and I propose that without considering these ancient sources and their stories, we cannot understand maternal mortality with so few women experiencing it and those affected experiencing it every year in the United States. And so I propose that looking at the ancient sources gives us an example of not just the effects on the mother and the baby, but also societal effects and cultural effects of maternal mortality. For example, and this was a question addressed at the Undergraduate Symposium, I was asked, what kind of cultural effects do we see from maternal mortality? Well, in a society that deals with a lot of maternal mortality, you see a greater emphasis placed on choosing a wife that's not going to die in childbirth, and you see a lot of emphasis in remarrying. You see a lot of emphasis in marrying young and then remarrying over and over until you get your children. There's in fact, the value of a woman is less, which is very interesting and something to consider, and something that I will be considering further as I explore these topics. But that said, maternal mortality, in order to discuss it, and it needs to be a part of the discussion anytime we start addressing these issues, whether they're personal or societal, using the ancient sources is definitely the way to do that. I want to quickly acknowledge Professor Larry Bleak-Hay from the Department of Classics, who has been my mentor and is my mentor during this research, and who has also become a good friend. Professor Levaniuk at the Department of Classics for allowing me to pursue some of my research interests within the context of her undergraduate seminar on Greek and Roman marriage. Dr. Stephen Sharmad at the Everett Clinic and Charlene Jenkins for providing me with consulting help. The Jim Greenfield Endowed Classic Scholarship Fund and the Harvey Bruce Densmore Memorial Fund for providing me funding. The UW Classics Department for their ongoing support. Kathy Carr at the Suzzalo Allen Library for providing some of the images you saw, the interesting ones of the inaccurate uterus and others. And Joyce Martin and her group at the Division of Vital Statistics at the CDC for providing the statistics that you saw today. Thank you.